Transforming care through genomic medicine, personalized therapeutics, health services and outcomes research, and innovations in healthcare delivery. We're Children's Mercy Kansas City, presenting our audio interview series, Transformational Pediatrics, with host Dr. Michael Smith.
Welcome to Transformational Pediatrics. I'm Dr. Michael Smith, and our topic is the 5 most common pitfalls in diagnosis and treatment of Group A streptococcal infection. My guest is Dr. Angela Myers. Dr. Myers is Division Director of Infectious Diseases, Pediatric Infectious Diseases Fellowship Program Director, and Medical Director of Travel Medicine with Children's Mercy Kansas City. Dr. Myers, welcome to the show.
Thank you, Dr. Mike.
So in the title, we have 5 common pitfalls, and you list the first pitfall as testing young children. Why is that a pitfall?
Well, it's a pitfall for several reasons, but most importantly, young children rarely get strep throat. A child younger than 3 years of age who has an older sibling with strep throat and who has symptoms compatible with strep throat may in fact have strep throat. But the majority of toddlers who have a sore throat have a viral cause for their sore throat. And when you test them and they have a positive result, the likelihood is that result is actually colonization showing up. Additionally, rheumatic fever is very rare in the young child, which is the reason why we treat strep throat.
Right, and so with testing the young child, that could lead to obviously maybe overtreatment or mistreatment. As you mentioned, in most cases, it's a viral syndrome. So let's move on to pitfall number 2. You say that is testing those with non-specific signs and symptoms. Why is that a pitfall?
Well, it's a pitfall because between 15 and 20% of children in the winter and spring months of the year are colonized with strep throat in their throat. And again, if you test a child who doesn't have symptoms that are very specific for strep throat or they're consistent with strep throat, then the likelihood is that if you have a positive result, it represents colonization and not true infection. And like you mentioned before, then you're giving antibiotics unnecessarily.
Right, and so when it comes to testing, I think we'll get into this when we talk kind of like about an algorithm that you would like offices, like community offices to follow. But when does testing become appropriate then? I mean, what do you look for before you order those barrages of tests?
So that's a really good question. So in general, children typically have fever and they have sore throat. So a child should not be tested if they do not have sore throat, which is often the case. In addition to the sore throat, they need to have a lack of viral symptoms, meaning that they don't have runny nose, they don't have congestion, they don't have prominent cough. And they should have at least one physical exam finding consistent with strep throat. So they should have a red throat or pus on the tonsils or tender cervical adenopathy that indicate, that this patient likely has strep throat.
So let's go on then to pitfall number 3. You have that as testing those with viral respiratory tract symptoms. And that, I think, you kind of just hit on there a little bit, right? So we have viral symptoms, runny nose, that dry, hacky cough. Is that what we mean here? So we see those kind of viral symptoms, and we end up testing for strep, and that leads us down the wrong path, right?
Correct. It does lead us down the wrong path. Remember that even though strep throat is a common disease, it really is only represents about 20% of all visits to primary care or to emergency rooms and urgent cares. It really is only about 20% of sore throat visits. So the overwhelming majority are still going to be viral causes, and that's why it makes it so important not to trust children who do not meet the criteria before testing them.
All right. Pitfall number 4, repeat testing or use of serologic testing in asymptomatic, previously treated children. Why is that a pitfall?
Oftentimes, if repeat testing shows a positive result, then it represents colonization and not typically failure, especially if the child is asymptomatic. And in addition, we don't want to test asymptomatic children let's say, of a sibling who has proven strep throat, which oftentimes happens. Because, again, that child may be colonized and leads you down the wrong path of thinking that you need to treat something that you do not.
Yeah, so after treatment, after the course of antibiotics in this case, if they're asymptomatic, it's a following game, right? You're just going to have them come back, you follow up. If they remain asymptomatic, you let it go.
Correct.
All right, pitfall number 5, treatment with an inappropriate antimicrobial agent. What do you mean by inappropriate?
So that's a really good question. There never has been any resistance reported for Streptococcus pyogenes or group A strep against penicillin or amoxicillin. And those are the first-line agents to use in the setting of strep throat. But oftentimes we see children who receive a different drug, like ceftonir or cephalexin or even amoxiclav or amoxicillin clavulanate. And those are not first-line drugs to treat strep throat. People sometimes suffer under the wrong impression that the group A strep has become resistant, which has not ever been seen. The other piece to this, which is a little complicated, is that oftentimes parents believe their child to be penicillin allergic. The true rate of penicillin allergy among the population in our country is about 1%. And so most of the time when somebody believes themselves to be penicillin allergic, they're not. They received amoxicillin or penicillin at some point in time in the past, and they had a rash with it. And oftentimes that rash really represented a viral exanthem and not actually an allergy to the medication. And so careful history of what that rash was and what really happened, what were the events around the previous treatment is really important to kind of be able to tease out the people with true allergy versus those who just had a rash that was not really allergy related.
Right. Yeah, this is interesting to me because we know how important the correct diagnosis is, the right drug at the right dose for the right patient. This seems to be a great education or re-education opportunity, right? And I know Children's Mercy is a large hospital. Children's Mercy has a great influence on community doctors. Is there a plan to outreach to community doctors and re-educate about Strep A, true resistance, et cetera? I mean, is that something you guys are looking at?
So I'm so glad you asked that. So we've already done that. We one of my trainees, who's a fellow in infectious diseases, her big project is working with 3 pediatric groups around town right now to improve their testing strategies and the treatment of children with strep throat. And it's wonderful. The practices have really welcomed us with open arms, and they've been open to some minor suggested changes to just improve the already excellent care they're giving. And we hope to see some improvements and some changes here in the next few months.
In that same process, are you teaching the community physicians maybe like an algorithm to follow when dealing with these types of symptoms in patients?
Yes, in fact, we are. And there's 2 good algorithms you can use. One is through the Infectious Disease Society of America, and they have developed a clinical practice guideline for strep pharyngitis, and the algorithm they use in that document is quite good. And then there's another one through the American Academy of Pediatrics. And Dr. Jackson and I have recently developed an EQUIP module, which stands for QI in Pediatric Practices. And that algorithm is actually quite easy to use and good for pediatricians to kind of think about when they're diagnosing strep throat in their practices. And that will be available soon through the AEP this coming month.
And how open are you finding the community physicians to these algorithms? Are they open to these things? Are they putting them into practice? Are you seeing some of the outcome from your efforts?
So we haven't seen the outcomes from the efforts yet, but they have been very open to incorporating them into their practice and thinking of ways that will work for them. And every practice is a little bit different. And so I really encourage practices to think about that and how they can kind of implement things like this within their own practice. And, for a lot of it, is that they want us to help provide them with tools to talk with parents, to explain to the parent why a test may not be necessary, even though they've brought their child in for exactly that, and what the dangers are in over-testing.
One of the challenges in primary medicine, too, right, is patients come in and it's almost like they're expecting something to be done. They're expecting a certain lab to be done, expecting a certain prescription to be written. And sometimes it's just managing those patient and parent expectations, right?
Exactly.
Yeah. Dr. Myers, thank you for all the work that you're doing. It's great work, and I want to thank you for coming on the show. You're listening to Transformational Pediatrics with Children's Mercy Kansas City. For more information, you can go to childrensmercy.org. That's childrensmercy.org. I'm Dr. Michael Smith. Thanks for listening.